There's a relatively long history of immunotherapy in glioblastoma. There are people that have been developing vaccines, tumor vaccines for glioblastoma, also people doing oncolytic virus therapy for glioblastoma for decades, actually. So there is a history of immunotherapy development for glioblastoma. It's just changed more recently given the explosion of new information that's been derived from mechanism to newer therapies for immunotherapy in oncology in general. So, and currently immunotherapy in glioblastoma remains incredibly promising. There are many things that we're starting to understand about the tumor microenvironment and how the glioblastoma tumors interact with the immune system. However, the current iteration of the immunotherapies that are available in oncology, with those immunotherapy agents, there hasn't been much success currently in glioblastoma. So, for example, the immune checkpoint inhibitors that are, many of them are FDA approved, many of them are in early and late stage clinical trials for other cancers. To date, there's been generally very small percentage of patients with glioblastoma that have benefited from these drugs. One of the main reasons that we think that's the case is the concept of the immune microenvironment and how immunogenic the immune microenvironment is around cancer. So in general, what's coming out of recent literature in immuno-oncology development is the concept of hot and cold tumors with regards to the immune system, so immune hot, immune cold. Glioblastomas are amongst the coldest tumors with regards to the immunogenicity in all of cancer. So the glioblastoma tumors, they have very little T cell infiltrate, the effector arms of the immune system. The T cells that are in the tumor are scattered and sparse, and the ones that are there tend to be Tregs, or the immunosuppressive T cells. The other things that have been associated with response to immunotherapy in other cancers have been things like tumor mutation burden, which has gotten a large recent focus. Glioblastomas are on the lower end of tumor mutation burden in all, if you take a spectrum of all cancers. So, and also therefore the predicted neoantigen burden, or the predicted neoantigen load, is actually on the lower end compared to other cancers. The other, some of the other factors that we think might predict for immunotherapy response in other cancers are things like PD-1 and PD-L1 expression within the tumor. In general, the PD-L1 expression, if you take all of the glioblastomas as a group, a very small percentage of glioblastomas have high PD-L1 expression and high PD-1 expression in the tumor. So those are some of the factors of the tumor immune microenvironment that affect how, in general, we think cancers will respond to current immunotherapies. And glioblastomas, amongst all the cancers, are some of the most immunosuppressive and immune cold cancers that we've studied. What we're also learning about glioblastomas when they recur after primary therapy, so first-line therapy, which consists of radiation and chemotherapy with a drug called temozolomide, when these tumors recur, there's more recent evidence that they actually become even more immunosuppressive, and that immunosuppressive microenvironment is not just immunosuppressive T cells. These are myeloid-derived immunosuppressive cells, neutrophils, macrophages, and they create an even more immunosuppressive microenvironment. So when we test these immunotherapies in the recurrent setting after standard therapy, we might be actually stacking the cards against the immunotherapy, trying to test these drugs in the recurrent setting. With regards to resistance after initial response to immunotherapy, unfortunately, we have very few patients who did respond to immunotherapy. So in terms of the escape mechanisms from immunotherapy, we really know very little in glioblastoma.